Okay, everyone. Well, I think we're going to get started, and looks like good timing. We have some people just coming in just now. Can everyone online hear me all right?
Yes,
Okay, it
we
looks like
can.
people online can hear me. Perfect. Well, I think most of the people in the audience have already met me, but for those online who have not, my name is Nathan Lambert-Cheatham. I'm one of the fourth year neurology residents here at U of L, and I'm also have had some prior neuro-ophthalmology training. So I'll be presenting grand rounds today, and for the topic, I chose giant cell arteritis. I picked this topic because I think this is a condition that many providers can feel particularly uncomfortable with. If you look at the research, you'll see that the research is very inconsistent um, in terms of specificity, sensitivity of a lot of our diagnostic tests, reports vary widely. And as a result of this, this is a condition that can be both prone to being underdiagnosed, uh, leading to severe complications, the most notable permanent bilateral vision loss, but can also be prone to overdiagnosis and overtreatment, which also can have its own complications. So my hope is that by during this talk, I'll discuss some of the new research in giant cell arteritis. I'll discuss some neuro-ophthalmic pearls and pitfalls that people can experience in evaluating this condition. And hopefully, through this, people will feel more comfortable in their diagnosis of giant cell arteritis and be able to most effectively treat patients. And for anyone who's doing this for CME, here at the bottom is the CME code. And at the end of the presentation, there'll also be a CME code. To start with a very basic, so what is giant cell arteritis? So to uh, kind of a very general definition. So this is a medium to large vessel vasculitis characterized by inflammation surrounding the internal elastic lamina. This inflammation tends to lead to several characteristic symptoms, which we're going to discuss shortly. But the most notable that is probably most feared by providers is the potential for permanent bilateral vision loss. So just real briefly, let's talk about the history of giant cell arteritis. Most sources attribute the first kind of evaluation of giant cell arteritis to ophthalmologists in 10th century Baghdad. It's not really clear if the patients he saw were true giant cell arteritis, but he was the first to describe a relationship between inflamed arteries and various visual symptoms. Then probably a more modern giant cell arteritis was first described in 1890 by Jonathan Hutchinson. He was both an ophthalmologist, pathologist, and let's see, I think he was also a dermatologist for his time. So he described a patient who had painful red streaks on his head that were so uncomfortable he was unable to wear a hat. And he described this condition as thrombotic arteritis of the aged, which was usually the first kind of medical name for giant cell arteritis. A few decades later, in 1932, Bayard Horton, who was a headache specialist, reported two patients who presented with fever, weakness, headache, pain, difficulty chewing, transient diplopia, and vision loss. And his team was notably the first ones to perform a temporary biopsy, which described the well-known histopathologic findings of granulomatous vasculitis. So the temporary biopsy that we get in a lot of these patients when we're concerned, he was the first one to do it. And for a period of time, this was known as Horton's disease after him. Then probably one other notable historical figure, about a decade later Gilmore, who was a pathologist, was the first one who looked at these temporary biopsies and described the more specific finding of giant cells, for which giant cell arteritis currently gets its name. So let's talk about a little bit about the pathophysiology and etiology of giant cell arteritis. So as we discussed, giant cell arteritis is a granulose inflammatory reaction of medium to large size arteries. And particularly what characterizes the types of symptoms is that these tend to affect arteries with very prominent internal elastic laminas. So some of these arteries that do have these prominent internal elastic laminas are the superficial temporal artery, for which we get scalp tenderness, the ophthalmic artery and posterior ciliary artery, which can lead to vision loss, and also not as often discussed, but also the aorta, which can also be involved in giant cell arteritis. Other arteries that do not have a prominent internal elastic lamina, notably the cerebral arteries, are very rarely affected. And this is why it's very uncommon to get a stroke in giant cell arteritis. So if we look at here's some kind of diagrams of what a temporal artery or a similar artery might look like. So if you look at the histopathological staining, you can see that there's a kind of on the outer side of the artery, there's the vasa vasorum, the tunica adventitia, you have the external elastic lamina, you have the muscular layer, the tunica media, and then the area of interest is right here, right between the tunica media and the tunica intima, which is the internal elastic lamina. You can see it very well on this section because they're using specific elastin stain. And this is the area where inflammation seems to be focused in giant cell arteritis. In terms of the exact cause of giant cell arteritis, we don't fully know. Some people think it's an autoimmune reaction, especially against the internal elastic lamina. That's supported by the fact that these people tend to have elevated inflammatory markers. It tends to affect arteries almost exclusively that have a very prominent internal elastic lamina. And some have suggested that this tends to happen in only those of older age because in order for this to occur, there has to be a lot of long-term artery damage, which exposes the internal elastic lamina to the blood flow. That's one theory that has been out there for a possibility of why it occurs more commonly in people of older ages. There's also they have done like genetic studies, and there are a few families that tend to have giant cell arteritis much higher prevalence in their families, which suggests that there's might be a genetic component, though there's no very clear and obvious gene associated. So when you get inflammation of these arteries that have prominent internal elastic laminas, eventually the intima will thicken, and this will eventually occlude the lumen, causing claudication and causing ischemia to various tissue. And this is what leads to very specific symptoms and signs. I think this is an important part to pay attention to because it's very easy to kind of generalize these symptoms, but they're very, based on their pathophysiology, they can have very specific findings. So first, probably the most common symptom that's described in giant cell arteritis is new onset headache. This is the most common symptom. Classically, it was described as a unilateral throbbing and pulsating headache, which kind of makes sense. You would think an artery being claudicated, it would be pulsating, and be maybe unilateral if that's probably that side is more likely to be affected. However, more recent studies have shown that the headache varies quite considerably, and that's actually probably a rare type of headache presentation for giant cell. The sensitivities for this finding vary greatly in the literature, but most seem to suggest close to around 75% of patients will have a new onset headache. And specificity values will also vary widely. However, in real life, if you're looking at a patient with purely new onset headache, in isolation, that's a very, non-specific and has negligible specificity. However, could clue you into if someone has a new onset headache and there's not a clear reason why, it might clue you into kind of ask about other symptoms of giant cell arteritis. And this brings us to a much more specific symptom that we hear about, which is scalp tenderness. So this is due to mostly the superficial temporal artery as well as surrounding arteries uh, being inflamed, getting claudicated, and then getting ischemia to tissue. And very specifically, this is pain to palpation over the temporal artery. So this isn't just a pain on the temporal side. A lot of people with headaches, it's very common for them to describe pain in the temporal side or pain behind the eye, which might make people immediately jump to concerns of giant cell arteritis. Very specifically, this is going to be pain over the temporal artery to palpation. So many times I'll ask patients, "Oh, here, take your fingers and rub over your temples. Does that make the headache better or worse?" If this is giant cell arteritis and they have an inflamed temporal artery and you're rubbing on it, it's going to hurt. But a lot of other headaches, people with tension headaches, many times will say, "Oh, due to probably a kind of like a, I imagine like a gated, kind of a gate theory of pain." When they rub over this area, they many times describe that their headache is better. Similarly, these patients many times are described as patients who, after all this started, they'll stop wearing hats because wearing hats hurt. They'll stop or avoid combing their hair because combing their hair hurts. So it's very specifically not pain just on the temples, it's pain to pressure. And I think that's when you evaluate it in that setting, there's a very specific finding and one that should lead someone to consider giant cell arteritis. A few of the other systemic signs and symptoms. So, probably what's usually considered the most specific sign and symptom is jaw, and actually, if it's prominent enough, it's also described as tongue claudication. So, similarly to the scalp tenderness, this is from arteries in the jaw being claudicated, ischemia, and thus, when someone tries to use their jaw, they'll gradually develop achy and stiff pain. Notably, this is not pain just at the jaw at baseline. There's not pain at the jaw just as soon as you move your jaw. A lot of these patients with giant cell, typically the age is in the 70s, 80s. It's very common to have TMJ with these patients. So what you look for is that pain with continued chewing. So these patients will say, "Oh, I stopped eating steak." Or some people actually have a chewing gum test that has been validated to some degree, where people will start chewing gum, and if it takes up over 2 minutes for them to develop the pain, then that's a sign of a very specific sign of claudication. Um, claudication versus TMJ, where many times patients will describe, "Oh, my jaw is clicking." Well, that's not going to be from giant cell. They'll describe pain as soon as they opened their jaw, which would be a very atypical for a claudication symptom. It usually takes prolonged muscle action. Naturally, if someone's having jaw claudication or if they're just having systemic inflammation, this can lead to unexpected weight loss and anorexia. So that's also a sign of giant cell arteritis. And one that I don't think is discussed as often, but especially in the early described cases of giant cell arteritis, the ones who had the most severe course, the ones who developed vision loss in one eye and then a couple days later developed vision loss in the other eye, a large portion of these patients had fevers. So if you look back at some of those older cases, they described about 15% of patients had a temperature over 102.2 degrees Fahrenheit. And these are many times the patients who had a much more severe course. And then one other systemic sign symptom that's commonly described is myalgia, or very specifically polymyalgia rheumatica. Classically, many people quote that as many as 1/3 of patients with giant cell arteritis have polymyalgia rheumatica. However, you have to kind of keep this in mind that polymyalgia rheumatica is a clinical diagnosis. They have some clinical criteria, which it doesn't seem like any of them have been really decided on as this is the diagnostic criteria. But if you look at the proposed diagnostic criteria, many of them uh, describe elevated inflammatory markers, advanced age, symptoms resolving with steroids, which these are the same symptoms you would expect in giant cell. So almost if you have a classical giant cell patient, just by the definition, they're almost many of them are going to have polymyalgia rheumatica. This being the case, if someone's been especially recently diagnosed with polymyalgia rheumatica, that puts them at high risk of giant cell arteritis because of the significant overlap in symptoms. That was some of the systemic signs. Now, as I discussed earlier, the signs that most people worry about in giant cell arteritis, at least the ones that are most dreaded, are many times the ocular symptoms, most notably vision loss. So let's talk about that a little more specifically. So vision loss from giant cell arteritis is going to be due to ischemia, to tissue due to claudication of arteries, most notably the central retinal artery, the ophthalmic artery, the posterior ciliary artery. And this will most classically lead to ischemia to the optic nerve. So this is the cause of vision loss in 90 to 95% of giant cell arteritis cases. There are two types of vision loss from ischemia to the optic nerve. There's anterior ischemic optic neuropathy, and then there's also posterior ischemic optic neuropathy, which is much rare. So here's some pictures of two optic nerves. On the left side, you can see an optic nerve with clear blurred margins as a patient with optic disc edema, and specifically pallid optic disc edema. And then on the right, you can see a nerve is very pale, has a chalky appearance, which shows that this nerve has had nerve damage. In anterior ischemic optic neuropathy, which is the most common by far type of vision loss from giant cell arteritis, what you're going to get is, due to the ischemia, the nerve tissue is going to swell, and this is going to cause swelling of the nerve head. And then at the same time, they're going to have very acute, immediate vision loss. And then over the course of usually a couple months, the swelling will die down and they'll be left with optic atrophy. This is opposed to posterior ischemic optic neuropathy, where there will never be any swelling. People will have vision loss and then will just slowly develop this optic atrophy. The posterior ischemic optic neuropathy is very rare, but if you do see it, giant cell arteritis is one of the very few things that cause it. The only other classically described causes are usually prolonged surgery, so prolonged heart surgery or prolonged spinal surgery, especially when they're having trouble controlling bleeding, and with anesthesia, they're trying to keep the blood pressure and heart rate down. So most vision loss from giant cell arteritis is due to ischemia to the optic nerve, but there's also a decent number who have ischemia to the retina. So this is about 5 to 10% of giant cell arteritis vision loss. This is going to be in the form of either a central retinal artery occlusion, a ciliary-retinal artery occlusion, or amaurosis fugax. So here are some pictures. In the left side, you can see a central retinal artery occlusion. You see the classic sign of a cherry red spot over in the macula. And this is due to ischemia to the retina, causing all the nerve tissue in the retina to become gliotic. It becomes white, starts obscuring the choroid. However, the macula, where there's not nearly as much nerve tissue overlying it, is spared, and that's why you get this cherry red spot right here. And then on the right side, you can see something people might not be as familiar with, but this is a ciliary-retinal artery occlusion. So ciliary-retinal artery is an artery that a large percentage of patients have. It's something that actually comes from the choroidal blood supply, and then from the choroid comes up near the optic nerve and into the more inner retina. And this artery is unique in that it has a very prominent internal elastic lamina, and thus it's been very well described as causing vision loss in giant cell arteritis. Then lastly, amaurosis fugax, which I think many of us are familiar with. This is going to be transient vision loss that's from ischemia to the retina. These patients will usually have a very short-term vision loss. Many times it's described as a vertical vision loss due to following the direction of the vascular arcades in the eye. And it should not be prolonged. So these patients aren't typically going to have 5 hours of vision loss and then their vision comes back. That should make you concerned for some other etiology that because retinal cells, optic cells in the optic nerve do not tend to survive very long without adequate blood supply. Yes, Dr. Brown. That comes from the choroidal blood supply, which is supplied by a few arteries, but most notably the posterior ciliary artery, which comes off of the ophthalmic artery. So ultimately, it's just a little downstream, but they too also have a very prominent internal elastic lamina, so they can be exclusively affected. Now, notably, there are some eye findings that will not typically cause vision loss. Note that a lot of these patients are elderly. There are many reasons someone could describe their vision as blurry in this patient population. Giant cell arteritis should not cause cataracts or cause refractive errors that are fixed with glasses. It should not cause vein occlusions, so central retinal vein occlusion, branch retinal vein occlusion, where you get the blood and thunder retinas. It should not cause vision loss from that. And it's very unusual for it to actually cause a branch retinal artery occlusion. And this is believed because the branch retinal arteries do not have a very prominent internal elastic lamina. The only one that does is the ciliary retinal artery, which is why that one's well described. But branch retinal artery occlusions, it's described in some case reports, but large studies show that it's actually very rare. So this is an area that I think is important to note is the cause of vision loss. If you're evaluating a patient with vision loss and you're concerned for giant cell arteritis, seeing if it falls into one of these categories can be helpful. And having an ophthalmologist or some sort of eye doctor take a look at these patients can also be very helpful in coming to a clear diagnosis. Now, the one other ocular sign symptom you can get is diplopia. So people can get binocular diplopia, and I won't go too much into the details, but you can get this due to a cranial nerve 6 palsy, a cranial nerve 4 palsy, or a cranial nerve 3 palsy. Many of these nerves do have supplies from the central retinal artery and ophthalmic artery, or very small branches from these. So that's how they would get damage to these nerves in the setting of giant cell arteritis. Sometimes in giant cell arteritis, you can see multiple of these. We had at least one patient when I was doing training up in Michigan State who had a cranial nerve 3 palsy, a cranial nerve 6 palsy, and I think they actually, for whatever reason, had a facial nerve palsy, which is very atypical. So whenever we see a patient who has a palsy like this, you should consider giant cell arteritis. It doesn't mean jump straight to, oh, this person likely has giant cell arteritis, but you should start asking about giant cell arteritis symptoms. You should start asking about their age, see if giant cell arteritis could be a potential etiology. Now let's talk about the demographics of giant cell arteritis because this can be very important and help you uh, have a much better understanding of the risk of a certain patient having giant cell arteritis. So the incidence of giant cell arteritis is typically reported between 1 and 30 per 100,000 people. So it's a fairly rare condition, but one that we can definitely see in our general population. In terms of race, is much more common in people of Northern European descent, and it's very unusual in patients of African, Asian, and Arab descent. Now, the age is a big focal point. As I discussed earlier, giant cell arteritis patients, this is a condition that affects elderly patients. So in most studies, the average age of diagnosis of giant cell arteritis is 75 years old. In large studies, they show that there's negligible number of patients who are under 50 years old. So in one of the studies that was, I guess is classically reported, is a study that looked at 140 some patients. In those patients, only 2%, 2.2% of the patients were between the ages of 50 and 60, and no patients were under 50 years old. Because of this, most specialists who deal with work with giant cell arteritis uh, basically kind of disregard the diagnosis once the patient is under 50 years old. Now, I'm not sure you should always do that. There are case reports. If someone comes in with very clear symptoms, they come in with scalp tenderness, jaw claudication, vision loss in one eye, you'd be very hard pressed not to consider giant cell arteritis. But just realize that as soon as someone is under 50 years old, just by pure numbers, they have less than a 1% chance of having giant cell arteritis. And then in terms of gender, this, as with many autoimmune conditions, this is more common in women. However, this is a very slight prevalence, and this is potentially just due to the higher life expectancy of women, and thus, if women are get to an older age, they're more likely to have develop giant cell arteritis. Okay, so now once you kind of assess the patient, you decide you're concerned for giant cell arteritis, you ask about these symptoms, especially the specific symptoms like scalp tenderness, jaw claudication, evaluate for any kinds of vision loss, and you decide, this patient might have giant cell arteritis. I'm concerned. Usually the next step is going to be lab tests. There are several very common lab tests that are run. So probably one of the more notable ones that people are used to hearing about is checking for a CRP or C-reactive protein. This is an acute phase inflammatory reactant. So if giant cell arteritis is acting out very acutely, the CRP is going to be more elevated. Many times this is very elevated, so this is more than 4 times the normal limit typically. However, it does vary a bit because uh, the normal range does vary by lab for CRP. So it's hard to get a study where you say specifically this is the threshold at which you should consider giant cell arteritis. The other lab test that most people are aware of just from med school ordering is erythrocyte sedimentation rate. This is more of a chronic reactant. If someone has been having giant cell arteritis for a while, the ESR will gradually increase. Note that ESR naturally increases with someone's age, and because of this, since we're in giant cell arteritis, we're looking at people who, just by the nature of the condition, are much more elderly. ESR is going to be elevated in most of these patients. However, we use a different cutoff, especially for giant cell arteritis, to determine if the ESR is elevated. For this, in males, what you do is you take their age, divide by 2, and that's the cutoff for erythrocyte sedimentation rate. And females, what we do is we do age plus 10 divide by 2. Is a recommendation from some older studies, and a lot of this because females tend to just naturally have an elevated ESR compared to males. Some other studies, you can look at elevated platelets, which are very common in giant cell arteritis, and many times people have had a standard lab test like this, so it's something that's easy to look at. And then if you do want to be a little bit more specific, you can also check a fibrinogen level. This is the most specific lab test we have for giant cell arteritis. However, it's not very sensitive. Probably the thing to note here is that if you check both an ESR and CRP in a patient, and the ESR and CRP are normal or unremarkable based on these cutoffs, then these patients have a less than 1% chance of having giant cell arteritis. You do have to consider the situation, though. There are a lot of patients who maybe by the time the ESR and CRP are checked, they've been placed on steroids, and that will completely invalidate the results. So if someone's on steroids, you can't apply this rule. But if you're first evaluating a patient, they have not been started on steroids yet, and you check an ESR and CRP, and those are unremarkable, then at that point, this patient has a less than 1% chance of giant cell arteritis, and you should reconsider that as a diagnosis. Now, once you get the ESR and CRP and get the results, if you're still concerned with giant cell arteritis afterwards, the traditional gold standard test is a temporal artery biopsy. So here on the right, you can see a little picture of a surgeon doing a temporary biopsy. This is a surgery, however, as far as surgeries go, is a fairly easy surgery to do, has fairly low side effects. Uh, what you do is you cut open the temporal area, you expose the temporal artery with sutures. You suture off both ends of the temporal artery and then remove it, followed by cauterization and closing up the wound. You might wonder, oh, don't people need this artery? This artery is obviously supplying blood flow. Will people not have complications from having one of their arteries removed? The answer is not usually. This area usually has good enough collateral blood supply that it won't cause patients any significant symptoms. However, there are reports of scalp wasting after surgery in some patients, though I have not personally seen a patient who's had this. So this is the traditional gold standard test. This can usually be done by vascular surgeons, oculoplastic surgeons. Even a general surgeon can do it, though I've had some a little bit of mixed results in that case. Now the sensitivities in the research vary greatly, and there's many reasons for this. Some is how the temporal arteries are evaluated themselves, whether a patient is placed on steroids, how common people are referred to temporal artery biopsy. Is it based on very specific symptoms or very general symptoms? Because of this, the sensitivity is usually reported at around 75 to 90 plus percent. And sometimes people can do a bilateral temporal artery biopsy, which increases your sensitivity by about 5%. At this point, if you're already considering a temporal artery biopsy, and since this is a fairly low risk procedure, you almost might as well just do a bilateral biopsy to increase your yield so you can have the most accurate data to base your diagnosis off of. Now, there's a few things to note. So, this is something that's been historically taught, and anyone who is familiar with giant cell arteritis probably passes this knowledge along. But giant cell arteritis can affect any artery with a prominent internal elastic lamina. It's not always going to be the temporal artery. It could not affect the temporal artery at all. It can also tend to have skip lesions where it will affect part of the artery, but then other parts of the artery close by will not be affected. And because of these skip lesions, whenever people get a biopsy, it is recommended to get 3 centimeters of length at least, and at least 50 sections of the temporal artery. Now, talking to pathologists, it's very rare to actually encounter a situation where the skip lesion would cause a change in diagnosis, but something that's been taught for a long period of time. And also, there are at least probably a few patients who this does increase the yield. That's a temporal artery biopsy. Now, one thing I think that is important to note, temporal artery biopsy is traditionally considered the gold standard test. However, as we kind of saw by the numbers, it's not a perfectly sensitive test. It's not a perfectly specific test. So it's something that's probably important to know a little bit more about what the temporal artery biopsy should look like in informing us of making a diagnosis. So if you look at temporal artery biopsy, this is the histopathologic slide I showed earlier of what temporal artery biopsy should look like. Notably, you have a very intact internal elastic lamina. So you can see it's very continuous, very uniform. Your tunica intima is normal size. There's not any hyperplasia, no thickening. You don't see a lot of very many inflammatory cells. You don't see any giant cells. So this is considered a normal temporal artery biopsy. Now, in the acute phase of giant cell arteritis, this is more like what your temporal artery biopsies might look like. Some of the notable things you'll see. So if you look at this one on the left, you'll see that there's significant intimal hyperplasia. So the tunica intima is much thicker than in the previous slide. So if you go back, let's see. If you go here, you see the tunica intima. You can barely see it at some areas. If you go here, the tunica intima is gigantic. It's obscuring the lumen significantly. And you can imagine how this would cause claudication and ischemia to tissue. Then you also see a lot of the dark lymphocytic infiltrate surrounding throughout the temporal artery, but also around the internal elastic lamina. You can see the internal elastic lamina here. It's not stained with a specific elastin stain, so it's a little hard to see, but you can still make it out here, and you can see that there are areas of it that are non-continuous where it just disappears. And then the most specific sign by far, this is the one that if you see this, you know there's very few things that cause this, is if you see giant cells. So here's a picture with some giant cells surrounding the internal elastic lamina. So that's, if you see that, there's very few things that can cause that, and that really makes you confident in a diagnosis of giant cell arteritis. Now, the problem with this is many times these patients are treated with steroids as soon as you're concerned in order to prevent bilateral vision loss. And because of this, there's concern, can the steroids remove this inflammation and make much less specific and less clear signs on biopsy? So what do you see in a chronic giant cell arteritis where there might not be any inflammation still present? The main thing you look for is you look at the internal elastic lamina. So all this inflammation is focused on the internal elastic lamina. This causes damage to the internal elastic lamina. And you can, even once the inflammation is gone, you can still see signs of that prior damage. So usually what you see is you see disruption, duplication, and scarring of the internal elastic lamina. If you look on this left side, you can see the internal elastic lamina here, and you can see that there's some areas where it disappears. And that's a sign of internal elastic lamina disruption. Similarly, if this has been an area of chronic inflammation, the internal elastic lamina actually eventually duplicates. And over here on the right slide, this is a patient who still has some ongoing inflammation, but you can also see some duplication where the internal elastic lamina is, you can see like 4 of them in the same, along the same path. So these are all signs that the internal elastic lamina has been damaged, potentially due to giant cell arteritis. Now, there's some things that make a temporal artery biopsy really hard to evaluate, and I'm going to talk about the 2 most common. So one is, let's consider giant cell arteritis is something that affects older population, people usually in their 70s, 80s. And as we'll see, this can sometimes be hard to differentiate from people with normal aging, especially vasculopaths who tend to have a lot of vascular damage. So this is a recent study, and what they did actually in this study is they had patients who are in the typical giant cell arteritis age but don't have giant cell arteritis agree to get a temporal artery biopsy. So what you'll notice here is if you look at some of these findings that we say, oh, this is temporal arteritis or a sign of healed temporal arteritis, things like internal elastic lamina loss, you'll see that even patients under 60 years old tend to have some level of internal elastic lamina loss. If you look at here, this 0.5, this would suggest an under 10% loss of the internal elastic lamina. By the time you're 60 to 80, you've lost, between 10 and 50% of your internal elastic lamina. By the time you're over 80, many patients have lost, close to around 50% of their internal elastic lamina. Similarly, if you look at intimal fibroplasia, you see a similar correlation with age. So many of these findings that we say, oh, this is signs of healed temporal arteritis, is also something you see in people as they naturally age, which can make this diagnosis really hard if you're worried about the inflammation being no longer being present. Some of the few factors that are a little bit more specific. So if you see adventitial lymphocytes, this is not very specific for giant cell arteritis, but it's not something that as clearly increases with age. So if you see that, that can be a sign that this is more clearly giant cell arteritis and not related to age. Also, you can look for internal lamina calcification, which is more common in just age-related atherosclerosis. So, as I mentioned, the whole reason we have to consider that differential, considering temporal artery biopsies in an older population versus temporal artery biopsies that are from giant cell arteritis, is because we treat these patients very early with high dose steroids, and there's concern of this removing the inflammation. Now, the research varies widely on this. There are some reports from pathology, especially in the pathology literature, who say, oh, as soon as 1 or 2 days after high dose steroids, all the inflammation might be gone. However, much more of the studies and much more of the studies and much more of the specialists in this area, for the most part, agree that the inflammation should still be there for at least 2 weeks after starting high dose steroids. In fact, the inflammation in a temporary biopsy after starting steroids might be there for much longer. So here's some data from a study. I believe this was around 2017. What they did here is they had patients who had confirmed giant cell arteritis, who had an initial biopsy as you would expect. However, then these patients were started on steroids, which they were on them for at least a year, and they were agreed to have a second temporary biopsy while on steroids at either 3 months, 6 months, 9 months, or a year out. So these were patients who have been on steroids for several months. And what you'll see is if you look at things, so one of the hallmarks of temporal arteritis is granulomatous inflammation. In the initial biopsy, 93% of these patients had granulomatous inflammation. On the second biopsy, this is several months later, still 58% of these patients had granulomatous inflammation that would be able to be seen on temporary biopsy. Other things like giant cells. So this is one of the most specific signs of giant cell arteritis. 55% of patients on initial biopsy had giant cells present. And then after months of being treated with steroids, still 45% of patients had giant cells present. So based on this, yes, the inflammation does slowly go away, but for most patients, it takes quite a while for this to occur. Let's see. Here you can see a graph of the granulomatous inflammation as these patients are treated with steroids. So at 3 months, you see that compared to the 93% of patients who initially had granulomatous inflammation, now 71% had it at 3 months, 67 at 6 months, 50% at 9 months, and 25% at 12 months. So it does take quite a bit of time for these inflammatory changes to go away in most patients. I mentioned this because there have been cases that I've personally seen where patients had a temporary biopsy. Maybe they had been on steroids for just a few days or maybe a week, and the temporary biopsy was read as positive due to usually disruption of the internal elastic lamina. However, you have to consider that when you're looking at that, it's very uncommon to have disruption of the internal elastic lamina without any inflammatory signs, just weeks or days after starting high dose steroids. So if that's seen, it's something you really have to reconsider. The specific patient I'm thinking of, we had a 40-year-old type 1 diabetic patient who had like an A1C of 15. She was being treated for active cellulitis and also had vision loss from diabetic retinopathy. And because that temporary biopsy was positive, she was getting ready to be treated with high dose steroids for probably a 1 to 2 year course. And naturally, that would be very detrimental to the patient. So being able to know what the findings in a temporary biopsy mean and being able to have some idea to correlate these findings can be very helpful. And naturally, having a very skilled and experienced neuropathologist is invaluable, so you can discuss the case with them to help come to a clear diagnosis. Now, because temporary biopsies, like I said, they are a surgery. They're not the most sensitive or specific in all cases. Some people have looked at ancillary studies to help support the diagnosis of giant cell arteritis. And this is one that actually surprised me. This has changed since I was seeing these seeing a lot of patients with giant cell arteritis, that's that a high resolution contrast enhanced MRI actually can be beneficial in the diagnosis. Traditionally, I've been taught that an MRI has a sensitivity of around 10% for giant cell arteritis, so quite low and probably only in a patient with a very acute presentation. However, more recent, well, here, let me show you what an image might be like. So here you see an high resolution contrast enhanced MRI. You see the temporal artery here, and then with contrast, you see an enhance. And more recent studies have suggested if this is done before steroids are started, it can actually potentially have a similar sensitivity or specificity to a temporary biopsy. They suggested this, and they've had a pooled meta-analysis more recently that suggests a sensitivity of 73% and specificity of 83%. This is like I said, this is a big change since I was primarily seeing these patients, so it's not something I can really vouch for by my own experience. I think it's very interesting, especially if these patients are able to get a very quick MRI before getting treated with high dose steroids. Other diagnostic tests, this one has actually been known about for a long time, but fluorescein angiography. So fluorescein angiography, this is a type of angiography that is commonly done by ophthalmologists, especially retina specialists, to assess arterial flow and filling in the eye. And what you'll see here on the left, I have a normal fluorescein angiogram. And what happens is slowly, when you inject the dye into a patient and start looking at their retina with a camera, you can see that slowly what happens first is the choroid starts to fill with patchy filling, and that usually just takes a few seconds, usually like 8 seconds, 10 seconds, something like that. Shortly afterwards, a couple seconds afterwards, you start to see the arteries fill with contrast. And then give it about 10 more seconds, and the venous system starts to fill with contrast. And then gradually that contrast washes out of the eye. However, what they've found is because giant cell arteritis does affect the choroidal blood supply, those arteries, like the posterior ciliary artery, do have a significant prominent internal elastic lamina. These patients tend to have significant delayed filling of the choroid. So here on the right, you can see a patient with giant cell arteritis, and you can see that the filling of the choroid itself is very patchy. And if you kind of have to look at the time stamps on it, but you'll see that it takes a prolonged period of time for the choroid to fill. In studies, they've shown that on average for a giant cell arteritis patient, it takes 69 seconds to fill the choroid. This compared to a normal patient where the choroid fills usually in less than 12 seconds. So because of this, if someone's presenting for vision loss being evaluated for giant cell arteritis, especially at an eye doctor's office, this is a very easy ancillary test to perform. And then one other ancillary test that has gained a lot of popularity recently is a temporal artery ultrasound. So this has been studied because they thought this would be a very easy point of care test. Someone could come to the ED, someone could even be in a doctor's office. A lot of doctor's offices and hospitals have an ultrasound readily available. And thought process is, oh, well, if this artery is inflamed, it has a lot of intimal hyperplasia, we might be able to see this just with an ultrasound. So in giant cell arteritis, the studies have shown that you can see this in an ultrasound many times, and what you'll see is an edema or hypoechoic halo surrounding the vessel lumen. So here on the left, you can see a temporal artery ultrasound of a normal patient. And then here on the right, you can see a patient with giant cell arteritis. Notably, what you see is you see this hypoechoic halo surrounding the lumen. And this can be a sign of giant cell arteritis. So multiple studies have been done because of how easy this test would be to perform. And these suggest a similar sensitivity and specificity to temporary biopsies. Specifically, at least one study reported that if there's a bilateral halo sign where you see a halo sign in both temporal arteries, and this is greater than 0.3 millimeters of hypoechogenicity, they reported that this had 100% specificity for giant cell arteritis. Because of this, a lot of people have thought, oh, this is great. We can use this to replace temporal artery biopsies. However, there are things to consider. So, talking with many people who have worked with people who were involved in the study or who have tried to implement this study had a very specific protocol. They had very well-trained ultrasound techs. And because of that, people have had a hard time reproducing this in clinics. I personally reached out to some of the ultrasound techs here, and they're had a lot of concern about trying to do this, and understandably so. In fact, I've heard that a lot of the physicians who are involved in the study do not implement this in their practice, probably because of the difficulty of implementing this specific protocol in patients. Additionally, this is meant as a point of care, so it is not meant as to be done on a patient who's already been treated with steroids. Okay, and now we just have a few minutes left, so I'll try and go through this pretty quickly. In terms of the prognosis of giant cell arteritis, so reports vary greatly, but what everyone worries about is bilateral permanent vision loss. Studies report that if a patient is not treated, this can occur in as many as 64% of patients. However, this varies a lot. I've personally seen patients who either refused to be treated with steroids or maybe refused a biopsy and didn't get diagnosed until over a year later, and some of them did not have any vision loss. So it's a really variable whether someone will acutely have vision loss, and it seems like the risk is particularly high if a patient is having a lot of symptoms, if their ESR and CRP are really high, or if they've had vision loss already in one eye. Note that the vision loss in giant cell arteritis is mostly permanent. Patient can get a little bit of recovery of vision as the swelling from the ischemia dies down, but those nerve cells or retina cells that have died from ischemia are not coming back. So this vision loss is not something you can wait until the vision loss and then treat. You're not going to expect that vision to come back. In terms of what the risk of having, if you've had vision loss in one eye, what's the chance of it happening in the other eye? It does vary quite a bit, but at least one study that looked at this early on showed that even if you treat it with steroids, as many as 9% of patients will still have vision loss. However, a lot of studies that have looked at this have shown that the risk of vision loss is decreased with steroid use. Then other than vision loss, patients can be at risk of a slightly increased risk of other vascular complications. Most notably, the aorta has a very prominent internal elastic lamina. So these patients are it's reported roughly around like a 6 times risk of developing an aortic aneurysm. Now, this still is a relatively minor risk. However, because of this, some providers do recommend getting routine screening several years after a giant cell arteritis diagnosis. And then very rarely, patients do end up having a stroke or myocardial infarction, though these are such rare complications, it's hard to tell in this population whether this is from giant cell arteritis or more just due to other vasculopathic risk factors. Now, the traditional treatment for giant cell arteritis, because of the research and how varied the protocols are, it's very hard to get a very clear, this is how you should treat giant cell arteritis. However, some of the traditional teachings, which seem to work pretty well, is that on suspicion of giant cell arteritis, people should be started on high-dose prednisone. There's usually around 1 mg per kg per day or 60 milligrams per day. It does need to be high dose because they have at least had some case reports where patients were started on lower dose and subsequently developed vision loss. Then after you get a temporary biopsy or you get some other confirmatory test and you feel confident in the diagnosis of giant cell arteritis, what you do is you switch patients to prednisone, usually around 80 to 100 milligrams daily, and then in some instances, providers will do a 3-day course of high-dose IV Solu-Medrol. There have been studies comparing this, and those studies have not shown a significant difference on whether you give them IV steroids versus just going to high-dose oral. So it's really provider preference. Probably not of much benefit unless the patient's already in the hospital for another reason. And then what you do with this condition, keep in mind, many times we think high-dose steroids are not something to worry about. However, keep in mind these patients are going to be on high-dose steroids for quite a while. So usually these patients are on high-dose steroids for, at least like a month or so. They're going to have routine checks of their ESR and CRP. And then once everything's stabilized, the inflammatory markers come back to near normal, their symptoms get better, then they're followed rarely, and the prednisone is slowly tapered by 5 to 10 milligrams every 1 to 4 weeks. And this is based on the ESR and CRP. So if the ESR and CRP start going up after you decrease the prednisone, then you probably are going to hold the course of prednisone. If they stay stable, then you can continue tapering the prednisone. There are some providers that also do it based on symptoms. However, studies have shown that trying to use the steroids based purely on symptoms does not result in better outcomes in terms of vision loss. And now, one of the things I want to talk about is usually we think, oh, well, we want to prevent bilateral vision loss, so let's treat this, save the patient's vision. We don't want to have a complication. However, keep in mind that the treatment for this, because it is high-dose steroids for usually 1 to 2 years, and these are in elderly patients, people in their 70s, 80s, who there can be a lot of complications from steroids. So this was a recent study. This looked at patients who are diagnosed with giant cell arteritis, who are placed on high-dose steroids, and looked at their mortality and morbidity over 15 years. Over this 15-year period, this looked at 43 patients, and they showed that 25 patients developed major steroid-related complications. Most common were fractures and severe infections. Notably, 19 of these patients died during the study period. 11 of them were during the first year. Now, these are older patients, so it is notable that they may have probably died of unrelated causes. However, most of them died within the first year when the steroid dose is at its highest. And also, at least 7 patients died from very clear steroid-related complications. So 6 had fatal infections, which were probably high-dose steroids probably did not serve them the best in that situation. And at least 1 had a fatal bleeding ulcer. So it's important to keep in mind in these patients that both the treatment and the lack of treatment can have potential severe complications. There really has to be a very clear risk and benefit discussion with patients. And then lastly, I think we're a little over time, so this is my last slide, or second to last slide, but real quick. There are some medications out there that can let us taper steroids quicker. This is usually prescribed by a rheumatologist. So tocilizumab has been the one that has the most gotten the most studies done. So they did a phase 3 clinical trial where they showed that tocilizumab allowed them to decrease steroids over the course of 6 months instead of it being over a year, and that these patients actually had improved remissions compared to patients who are just placed on steroids for roughly a year-long taper. So based on that, similar to other autoimmune conditions, it probably is beneficial to start these patients on some sort of immunomodulatory medication so you can bring those steroids down quicker and reduce the potential complications. There have been studies in other medications. Tocilizumab is the best studied, but also methotrexate has a lot of studies, and they're also studying a lot of other immunomodulatory medications for this. Naturally, immunomodulatory medications do have their own side effects, so that's something to consider, but usually they are better than being on long-term high-dose steroids. And then this is my last one. Giant cell arteritis is very complicated. You really have to take each of the patient's individual circumstance, look at each of their symptoms, decide what is the chance of this patient having giant cell arteritis, what's the benefits of treating them, do the risks outweigh the benefits? So there's no, if I was to make a full algorithm for this, it would probably be massive and way too complicated to digest it all. But here's a simplified algorithm of kind of how I go through a typical giant cell arteritis evaluation. So I look, does the patient have specific signs of giant cell arteritis? So once I'm decide I'm evaluating a patient for giant cell arteritis, I ask, do they have jaw claudication? This isn't just jaw pain, it's specific signs of jaw claudication. Do they have scalp tenderness? Not just headache in the temporal region, not headache behind the eyes, but specifically scalp tenderness. Do they have vision loss that is uh, which would make sense with an ischemic form of vision loss, like a central retinal artery occlusion or ischemia to the optic nerve? Once they have some of these specific symptoms, well, one, if they don't have these specific symptoms, I'd carefully consider reconsider the diagnosis of giant cell arteritis, because once you take out these specific symptoms, you have very little you're working with to decide on a giant cell arteritis diagnosis. If they do have some sort of specific symptom, or maybe some a symptom's unclear, it's not sure if this is jaw claudication or not, the next thing you look for is this patient over 50 years old. As we discussed, less than 1% of giant cell arteritis patients are under 50 years old. So if they are under 50 years old, you should carefully reconsider your giant cell arteritis diagnosis. But if they're over 50, you go to the next part. Now, they're over 50 years old, they have specific signs of giant cell arteritis, but you don't want to just start treating them just based on that, because this treatment has a lot of complications. So you check the ESR and CRP, and hopefully the patient hasn't already been placed on steroids at this time. If the ESR and CRP are unremarkable, then they have less than a 1% chance of giant cell arteritis, so you should carefully reconsider your diagnosis. However, if the ESR or CRP, if either of those, even just one of them, is elevated above the typical threshold, then this is the point where you need to really consider and discuss with the patient, okay, should we start steroids right away in order to try and prevent potential vision loss? You should discuss getting a temporary biopsy to help confirm the diagnosis. And you can consider discussing potential ancillary studies like the MRI, ultrasound, and fluorescein angiography. That gets a very complicated. Like I've had a patient recently who I was evaluating for giant cell arteritis, and they were adamant that they did not want steroids unless there was a 100% diagnosis. And well, luckily that makes it really easy. In that case, you can get an MRI scan, because MRIs seem to be very sensitive and specific, at least based on the studies, if they have not been placed on steroids. Also, a temporary biopsy is pretty good if they have not been placed on steroids yet. So that made it easy. But not all cases are going to be like that. Patients can be complicated. A lot of these patients, are coming in for a reason. That might be that they have an infection, have another autoimmune condition, which is naturally going to raise their inflammatory markers and make them have very similar symptoms. So it's a complicated diagnosis, but hopefully this talk has made people feel a little bit more comfortable in the diagnosis, a little bit have a better understanding of some of the new diagnostic testing we have a better understanding of the treatment involved and the potential complications. So here's my references. And with that, I'll open up for any comments and questions. Sorry for going a little over. Thanks. Yes, Prachi. Um, uh, Based on the study, it did not say it was specifically vessel wall imaging. So this was, yeah, not that I know of. Like I said, this is a relatively recent development, because when I was uh, in training, doing like neuro-ophthalmology training, I was always taught MRIs have like almost no use in giant cell arteritis. The sensitivity and specificity is so low, you're going to get a temporary biopsy anyway, so why worry about it? But these studies are something new, so I can't personally, from my experience, say, oh yeah, these are great, we should do this. But it, There are multiple studies reporting very high specificity and sensitivity. If these patients happen to be in the hospital, this is a very easy test. I'm personally looking forward to ordering more of these on my patients so that I can validate this myself. And yep, yeah. Yeah. Well, I know they show, at least on this study, showed that if a patient was treated with steroids, this was not sensitive or specific. I imagine the steroids reduce that intimal hyperplasia, which is crowding out the lumen, and probably makes it much harder to see. So I imagine that, and yeah, also one of the benefits of MRI, it can look at some of the other vessels because temporal artery is we always associate with the temporal artery, but it affects many other vessels. So most notably, people don't think about the aorta being involved, but it is. So with an MRI, you can potentially see inflammation other related vessels, which might be helpful. Of course. Let me see in the chat if there's any questions. Oh, looks like there's a few here potentially. Okay, so I think I see one thing in the chat. So how long should 80 to 100 milligrams of steroids be tapered? Yeah, so usually how long? So usually I feel like patients are usually on the high dose steroids for the uh, maximum dose for about a month. However, you do check ESR and CRP during this time. It's only once it starts to come back down to normal that you consider tapering. I don't think there's a very clear regimen for this, but yeah, once it has stabilized, then you can start considering decreasing steroids by 5 to 10 milligrams every 1 to 4 weeks. There are a lot of studies that support that. In terms of tocilizumab, I've had some patients on it, though I haven't prescribed it myself, but a lot of the side effects, it can cause elevated liver enzymes, neutropenia, leukopenia, increased risk of infection, though the increased risk of infection is much less than in patients who are treated with high dose steroids. Okay. Well, I think that'll be all. Thank you, everyone, and hopefully everyone learned something from the presentation. Thanks.